Now I invite Dr. Kavya Subramanian, who is working in Aravind Eye Hospital, Tirunelveli. She'll be talking on New Horizons, investigational drugs on the radar. Over to you, Dr. Kavya.
Good morning, all. Thank you for the nice introduction, and thank you, Dr. Soumya, for giving me this opportunity. I will be presenting on the newer investigational drugs on the glaucoma management. As we all know, currently we are focusing on the IOP reduction because that is the only modifiable risk factor which prevents the progression of optic neuropathy. From the cholinergic agonist, now we have reached and we have currently using the ROC kinase inhibitors, and which was introduced in the field in 2017. So coming to the proper topic, so why we need new drugs? Because only IOP reduction will not help us to control the glaucoma progression. We need to protect the optic nerve, so we need neuroprotective agents. And many our conventional glaucoma medications are having many systemic, which are contraindicated in systemic diseases like asthma and cardiac disease. So we need some drugs which can be used in these conditions, and many of the side effects are due to preservatives, so we need preservative free drugs, and new drug delivery systems are there. So we will be seeing these preclinical trials, the drugs undergoing preclinical trials and ongoing clinical trials, and in clinical use one by one. So first I will be stressing on the ROC kinase inhibitors because we are currently practicing, started practicing on this. So there are three agents, ripasudil, natasudil and fasudil. Fasudil is currently undergoing clinical trials. Ripasudil and natasudil has already came in the field. Their mechanism of action are three. They will increase the trabecular meshwork. They will remodels the trabecular meshwork and increases the outflow, and they will reduce the aqueous production and also lowers the episcleral venous pressure. And additionally, they will help in regulating the wound healing and fibrogenesis after the, especially after post trabeculectomy, and we can safely use this property in post keratoplasty patients as well. And it also increases the nitric oxide release on the optic nerve head, thus providing the neuroprotection. So if I am talking about ripasudil as an agent, it's the first ROC kinase inhibitor. It came in the industry, and it is a selective ROC kinase inhibitor. It's available as a dosage of 0.4% solution, which can administered as bi-daily dose, and it has a reduction of 3.7 millimeter of mercury from the baseline, and it is available as fixed drug combination along with the prostaglandin analogs and beta blockers. The second agent is netasudil. It came in the field in 2017. It has additional inhibitor action on the norepinephrine transporters, and it is available as 0.02% solution, and it is administered in once daily dose. Other fixed drug combination available along with latanoprost is it is named as rocklatan. The main side effects are conjunctival hyperemia. Because of its nitric oxide production, it will cause the vasodilatation, and the other is reticular corneal edema. Then these are the trials related to ROC kinase inhibitor, and ROCKET 1 and ROCKET 2 compared the effect of netasudil with the timolol, and it is they have proven that it is equally efficacious, and it is non-inferior to timolol. And Mercury 1 and 2 is the comparison of netasudil latanoprost combination with the netasudil versus latanoprost alone, and the fixed combination has proven higher IOP production compared to the monotherapy. The safety in pregnancy and lactating women is not known, and it is under trial. Then coming to the investigational drugs like adenosine receptor agonist, adenosine increases the activation of these adenosine receptors increases the outflow facility. So one example is trabedonosone. It is A1 adenosine receptor agonist and phase 3 clinical trial. The second one is cephaloprost. It is a prostaglandin analog which acts on the EP3 and F receptors. According to Angel study is a phase 2b randomized control study. It concluded that it has a comparable IOP lowering effect and safety like latanoprost. Then big potassium and calcium ionic channel modulators. It increases the level of nitric oxide. Example is latanoprostene bunod. It is a nitric oxide donor as well as a prostaglandin analog. its active components will increase the uvascular outflow as well as the trabecular outflow, and it is available in a dosage of 0.024% once daily dose. These are the trials related to latanoprostene binod and Voyager study, Constellation, Apollo, Lunar, and Jupiter study. They have proven that it is non-inferior to timolol. Then coming to local calcium channel blockers, where FML can be used, but the use is limited because of the systemic side effects. Then coming to prostaglandin, prostanoid receptor agonist, EP2 and EP3 receptor on its activation increases the uvascular outflow as well as the trabecular meshwork outflow. Example is omidipag, which is introduced in 2018. It is an EP2 agonist. Then coming to small interference RNA, these are a double stranded small interfering RNA which causes the beta 2 adrenergic receptor blockade and thus decreases the aqueous production. But whatever we are seeing with the commercial beta 2 blockers, the systemic side effects are not there, so directly we can use it. Is in the example is bamosiran. Then CRISPR-Cas9 RNA, it is it will cause the disruption of the aquaporin 1, because aquaporin 1 is a protein that is involved in the aqueous production. So this CRISPR-Cas9 RNA will interfere with this aquaporin and thus decreases the aqueous production. And gene therapy, adenoviral gene therapy is also under consideration in this. Then coming to cannabinoids, CB1 and CB2 receptors are present in almost all the ocular structures. This activated component of the cannabinoids like THC, it has a IOP lowering effect. It will act on CB1 and CB2 receptors, but the problem is it has a controversial use because as we know, it has side effects like dizziness, confusion, sleepiness and all, but it has additional neuroprotective effect as well. These are the routes like oral, intravenous and inhalation and topical formulations are there. Then other cellular cytotoxic modulators are there like ethacronylic acid and latanoglins, and cellular signaling pathways molecules are there, olmesartan and lometricin. Then latanoglin derivatives are there, macrolides, and inhibit actin polymerization and which increase the trabecular outflow. Then other drugs are under consideration are angiotensin 2 receptor agonist, 5-HT2 agonist, and anacotive acetate. Then alternative drug delivery systems. Why we need alternative drug delivery systems? Because it increases the drug retention, less side effects, increase penetration, and decrease frequency of administration and better patient compliance. First is Ocusat. It's a polymeric membrane coated delivery system of pilocarpine, but because of its disadvantage, it is withdrawn from the field, and these are soft contact lenses. They will elute the drug continuously. 1% pilocarpine is included in the lens will be equal to the 8% topical eye drop. Then this is Durista, or it is a bimatoprost implant. It is a sustained release biodegradable intracameral implant available in the dose of 10 and 15 microgram. It is FDA approved in 2020, and it elutes the drug for 3 to 4 months. The only side effect is corneal endothelial cell density will be decreased. This is nanotechnology. Actually, it bypasses the biological barriers, so it directly elutes the drug at the target site. So these are the examples like subconjunctival injection of dorzolamide, supraciliary injection of brimonidine, and intravitreal injections of brimonidine, travoprost, brimatoprost, and lead macrophages. And Timoptix SC is a newer timolol drug. Actually, once we instill it, once it comes in contact with the tear film, it will become a gel form. So sustained release will be there. This is beam ring. It is a bimatoprost ring, and it elutes the drug for around 6 months, and we can place it in the fornix as we can see in this picture. Then this is ocular punctum plug. It is a travoprost punctum plug which is used as a punctum plug, and it can deliver the drug over 90 days. It has a fluorescent property, so we can aid in visualization, and radiologically we can see that. Then this is IDOS. It is a sustained release intracameral travoprost implant which can be implanted intracamerally. Then neuroprotection, actually it is already explained by Dr. Soumya. So that's all. Thank you.
Thank you, Kavya.